and just go ahead and jump in.
Great.
All right, awesome. I have nothing to disclose, neither do any of the other hub representatives here. We're not affiliated with anything we're going to cover. We're going to talk about harm reduction today. I think that this is a really important topic, and I'm definitely not going to do it justice in 20 minutes. But the hope is to introduce the conceptual model just so you have some grounding in what is harm reduction in comparison with the other primary model in substance use, which is an abstinence only model. Also talk about how harm reduction can really be beneficial with working with individuals with a substance use disorder, and why that may be a good fit, or sometimes even a better fit for people in terms of their recovery journey and their recovery goals. And then I'm going to at the end just introduce a handful of harm reduction techniques that are kind of core techniques that you can apply at any point in your treatment with somebody. They're things that you can just readily use. It doesn't have to come along with an entire harm reduction protocol. So just wanted to illustrate that because it may actually be things you're already doing and can now align in the category of harm reduction. So the way that I like to kind of start talking about this topic, because I think it's less so in recent years, but historically there's been some controversy around harm reduction, like one person was saying, and I'm sorry, I can't remember the who was discussing it because I was multitasking, but the discussion about how medication a replacement may not be routine in some communities, in some areas. I think that is an example of how harm reduction has not really fully been incorporated into the standard of care that we want to be providing to individuals with substance use disorder. And I think one piece of that is the historical treatment of substance use disorder and the stigma that is still very much present there. And so I find that it's helpful if there's any part of attendees who may still not totally be sure if harm reduction is an okay approach, or where that fits into how you're working with this population. Important to kind of do a thought exercise and think about how this applies to your own life. So I always encourage people to first start by questioning themselves, and you don't have to chat in or respond to this, but just think in your own mind, how do you handle stress or distress? How do you handle difficulties when they pop up in your life? Because that's part of being human, that we're going to experience stressful things, or relationship discord, loss, maybe even trauma. And those things can really put a strain on how we're coping. And so if you think about the ways that you would manage difficulty in your life, whether that's, maybe binge watching Netflix, or hanging out with social supports, friends, family, exercising, and any of the things that might fall into a category of how you would cope, how you would manage that negative emotionality. And now imagine that someone said, just stop doing that. You're not allowed to do that. Or if someone actually took it away, the one activity or the one thing that helped in that moment, that made you feel better. Or if somebody actually put you in jail or punished you for doing that thing that you were using to manage difficult life circumstance, painful emotions, family or work stress, or even made you feel as if you were bad or broken for capitalizing on that, for pursuing something that gave you comfort, or took away the loneliness, or helped to manage the anxiety, the sadness, the fear that was present there. Because I think that's how a lot of our patients are feeling when we're talking to them, when society, when loved ones are talking to them about their relationship with substances of abuse, that this is a genuine relationship that, yes, it brings a lot of negative consequences, but it also brings comfort and relief from some of these things, albeit temporary. It serves a function. And so when we have a perspective on it that is all or nothing, that can put people in a really difficult situation. And so harm reduction is something that has come out of later perspectives on substance use or addiction in general, because historically we've treated this population very differently from people with other chronic health conditions. And that history is still very much with us in society in different communities. So over time, we viewed addiction from a criminal vantage point. So we viewed it as a crime. We've incarcerated huge numbers of individuals or removed them from society at different parts of the temperance movement, for instance, put them on farms or programs, sometimes for many years on the outskirts of society, removed them from their communities, their families. And that has had, that is very much still with us today. We've also viewed addiction as a moral failing or a problem of willpower, which we know there's almost no evidence to support that that this perspective is still very much with us. This idea that if I'm struggling with addiction, I lack motivation, or I lack willpower, or maybe even I just have a weak or addictive personality, which there's no evidence that supports that that's a thing. In fact, we know that how substances of abuse affect the brain as human beings, we are very prone to addictive patterns of behavior. So this isn't unique to that individual. We've also had a period of time where we viewed addiction as a disease, and I think that language is still very much with us. And there is validity to viewing it that way, but it doesn't quite capture the whole picture of what's going on with substance use disorder, and that it isn't as straightforward as maybe some other disease processes where there's sort of a cause and effect relationship. So it isn't until recently that we've been able to view substance use disorders as what they really truly are, which are complex, multifaceted conditions that are greater than the sum of their parts, right? It's the combination of how an individual's psychology, physiology, social and environment variables have been impacted, have been changed, and are now interacting in this dynamic that contributes to the full presentation. And so if we're not looking at all of those domains when we're seeking to help somebody or treat somebody with these conditions, we could be missing a really big part, right? So that's why it's important that we understand as helping professionals that work with individuals with a substance use disorder, that addictive conditions are really a chronic disease. They're very similar to other chronic conditions such as asthma, hypertension, diabetes. There's a large genetic contribution, some studies showing 50 or greater percent genetic contribution. That's higher than most cancers. That's higher than things that we routinely talk about, or, oh, that's just my genes, or you got that from grandma, when we're talking about hypertension or high cholesterol. So substance use it has a very high genetic vulnerability associated with it. We also know that similar to other chronic conditions like asthma or type 2 diabetes, that it is this interplay between personal choice and the environment. And that's comparable. It's not that people don't have any agency in the onset or maintenance of this condition, but that it's really complicated. And the role that substances are playing in their life is equally complicated. Medication adherence and relapse rates are very similar to other chronic conditions. And so the recommendation is long-term treatments that are really focused on functional improvement instead of an absolute cure, right? So from a harm reduction perspective, which I'm going to talk about some of the specific criteria, it's recommended to view addictive conditions and their treatment as something that's continuous rather than episodic, rather than waiting for people to get engaged in this sort of I relapse and I engage in treatment, and then as soon as my symptoms are in remission, I'm not in treatment. But to think about a continuum of care that patients can step up and step down in terms of the intensity of service, really focusing on global improvement, which may or may not include abstinence. So that is not the only successful outcome. That people can, in fact, be successful with moderate levels of use, regardless of the substance. And so really working with them to figure out what are their recovery goals, what's going to be the best course of action for them to adjust this relationship with substances. And that harm reduction is a very effective intervention, and it's shown good outcomes regardless of whether it's alcohol, illicit substances. It has good indications for helping people improve that social functioning, personal functioning, health functioning, and that in general, it can reduce threats to public health and safety and save the entire health system. So it is an absolutely effective means of working with patients. Where does harm reduction fit into that continuum of care? Typically, we would recommend, although you can use it at any point in time with patients, that it's really helpful in the beginning of treatment engagement. That when people are first, they're highly acute, they're first starting their treatment journey, that harm reduction techniques can be very helpful for helping them to start even just learning about their use behavior, what their patterns are, where they fit, and what they're willing to do in terms of positive change, how they're willing to reduce, but not necessarily focused on an abstinent goal right off the bat. So it's very helpful to use harm reduction at the beginning of treatment protocols, although you can use it at any point, and especially when people have a slip or a lapse, to go back to harm reduction models. So what is harm reduction? Well, in a nutshell, it includes all of these kind of big picture ways that we think about working with patients. So having respect for the individual, their unique needs, values, preferences, accepting them for where they are right now in their journey. Really seeking, if we're providing education or skills or techniques or whatever the intervention method is, that the ultimate goal is to empower them with that knowledge to be able to make informed decisions about their relationship to the substance. Having compassion that this is really hard, and collaborating with them on their unique treatment goals, that we're not going to be making the statements of what they need to or have to, that they drive the bus, and we just collaborate and suggest and use motivational techniques to help people in making those decisions. Now, we use harm reduction all the time, in fact, so it's in a nutshell, anything that is in the service of decreasing harm. So things like sunscreen, seat belts, bike helmets, these are all routine harm reduction methods. Medication-assisted treatments like opioid replacement therapies, methadone, buprenorphine, even nicotine patches, all of these things that are substituting for a substance that is safer, it would fall under the harm reduction. Things like clean needle exchanges, having safe healthcare run injection sites. I know we don't have that here in New Mexico, but in other parts of the world, that has been shown to be very effective. And providing things that decrease other forms of harm, such as condom distribution, sex education, and infectious disease testing and prophylactic medications. All those things would fall under the harm reduction umbrella. So the main goal is to reduce harmful consequences associated with any high-risk behavior, and substance use is included in there. So it's a very solution-focused approach. It helps people to just be as safe and healthy as they can be right now, as in today. So the nice thing about harm reduction is we don't have to wait for specific outcome or goal, that we're having active conversations. What can you do today to be as safe and healthy as possible? What's going to keep you alive to help you move towards greater functionality over time? Our ultimate goal is to keep people engaged and retained in treatment. That's going to help them in the long term. So really applying things that don't force a standard or a judgment or an unattainable goal, that isn't confrontational, that doesn't put them in a position to either leave treatment or be forced out of treatment because of the symptoms of their condition, right? If they're actively using, they're lapsing with their use, those are all par for the course. And so we really want them to be successful in treatment and to move towards greater levels of safety, whatever that means for them. So here are some studies that really can exemplify the use of harm reduction. This one is illustrating buprenorphine maintenance versus detox, which would be showing the green line are the folks that, or the green levels are the folks that were placed on a detox protocol. And within a very short amount of time, we had a high dropout in treatment, and 4 deaths, versus the harm reduction approach, the buprenorphine approach, much higher retention in treatment and 0 deaths. So right there's a real stark comparison to how using a harm reduction approach can very much benefit, especially the opiate use disorder population. And this study is illustrating the impact that it has not even on use behavior, but on associated problematic behaviors like engagement in criminal activity. So by doing nothing other than providing methadone treatment within the population that was sampled here, you can see the engagement of criminal behaviors prior to methadone maintenance treatment are the blue lines, very high numbers. And then during treatment, a huge drop in engagement in criminal behavior. So that's another area that we can have really positive impact by applying harm reduction. And then this study, which is even a little controversial today, looked at how can we increase safety and decrease death associated with overdose and HIV infection in a population in Switzerland. So what they did was they studied a subset of patients who did not do well on buprenorphine or methadone and were failing out of those treatment protocols. And so they decided to provide them pharmaceutical grade heroin with clean needles. That was the only thing. They didn't change the drug whatsoever, and they applied this in I think it was 1994 was when they applied that harm reduction method, and you can see a really clear decrease or correlation as soon as they implemented. The only change was that it was essentially pharmaceutical heroin that was free from things like fentanyl or other additives, and they provided them clean needles. They saw a huge decrease in the number of deaths due to overdose related to that drug, and deaths due to AIDS related to using use needles. And so that right there is a perfect example of how we don't even have to change the use behavior itself, and we can apply a harm reduction approach and see improvements in terms of safety. So from this philosophy, we're really focused on understanding that people who use substances are experts in their own experience. We want to collaborate with them on what their goals, their values, and needs are, that they have strengths that can be applied in the service of making the positive changes for themselves, and we can align with those strengths, that substance use is really complex, exists in complicated people within complicated social situations, and that we can categorize it along a spectrum of the harmful consequences that use may be creating, rather than seeing drugs in and of themselves as bad, or the use of drugs in and of themselves as bad. So really understanding that it really does exist on a continuum. So what are some of the skills that you may already be using or that could fall under this harm reduction umbrella? One of the core skills that we tend to do early on in treatment, and I just want to caution, you wouldn't do something like this with somebody who's already in contemplation, so they're already ready to make a change, because you might actually increase the ambivalence, and that's not what they need. But if you're working with people that are pre-contemplative, they're not quite ready to make a change yet, using a decisional balance is a great harm reduction technique. And so this is essentially a fancy pros and cons list. So you can see on one side we have a column of continuing the behavior, and the other side we have a column of changing the behavior, and then the row is split with the benefits of continuing the behavior versus the cons of continuing the behavior, and the cons of changing the behavior and the benefits of changing the behavior. So we're really comparing and contrasting those two things. So here's an example of what that might look like if we did this with a patient. And I want you to note one of the things that people often miss when they do this is providing a numerical rating for each item. So you can see next to each item listed is a number, and that number is like 1 to 10. So how much of a benefit would this be to you out of a scale of 10? And how much of a cost would this be to you on a scale of 1 to 10? What this allows you to do is the next step of the decisional balance, which is ranking those things. So looking at, okay, where are my 10s? So actually continuing the behavior, the most beneficial to this patient is that it helps them deal with their pain, versus the benefit of changing the behavior would be if they could get assistance with dealing with that pain. So that helps us to create a hierarchy of need that is disentangled from use or not use, and just allows us to focus on what's truly important to this individual in the service of greater health. So if we were to focus on managing their pain as number one, there's lots of ways that we could come at that problem without having to really get into any kind of a discussion about use or no use, or what they're going to do with that use, right? So this is an important piece of doing a decisional balance, is making sure that you're building that hierarchy, because the hierarchy is what will drive the treatment goals and perspectives. The next thing that's a big part of harm reduction is any kind of tracking or logging that gets some of the core pieces that we can start to have conversations about. So here's an example of a written out functional analysis, which helps us to identify the triggers, both internal and external, the behaviors that are related to those triggers, and then the long-term, short-term positive and negative consequences. So that really helps us to think through what is the connection between what's triggering the behavior, what might be maintaining it, and then what are some of both what it's doing for them, but also what it's not doing for them, how it might be harming them. And so here's an example of what that would look like written out, and how we could actually intervene, or we could help them to understand where they could start to make changes in this pathway. Here's another example of ways that just a really basic one of how we could start logging and tracking and looking at the cravings or urges to use, and then other behaviors that could be used to cope with that instead of use. And then in general, whether we're using one of these types of things or one that's written out in a linear format, we could also just collect that information and have conversations with them around all of the different variables that are connected to the drug itself, the setting in which they use it, and then their individual set, what it does for them, their history with it, the meaning that they're making out of it, right? So having those conversations. And then the last core technique that's part and parcel with harm reduction is doing high-risk situation planning. And this is something that you can tag on to every single session you do with somebody. And that's where you just talk through, between now and the next time I see you, what situations are you aware are coming up that pose you high risk to either engage in, whether that has to do with any kind of risk, their sexual behavior, risk for violence, risk for overdose. So looking at what are the risks that are showing up in their life over the course of that next week or month, and then listing them out and talking through some concrete plans that they can apply to be able to manage that risk more effectively. So there's a number of high-risk situation worksheets out there that you can download and you can fill out, or have the patient fill out, just to start to practice thinking differently. What's coming up in my life that poses me risk, and how do I want to manage that to decrease that risk for increased health and safety? So that's all I got with this one. Were there any questions or comments?
Hi, folks.